This webinar on Pilotitis, a digital health epidemic. My name is Alex Mejia. I am a division director at UNITAR, the United Nations Agency for Training and Research, and I am speaking to you from the Palais des Nations in Geneva, Switzerland. It is my great privilege to be able to chair, at least initially, this very interesting webinar that we have prepared for you. And I would like to thank in advance the panelists and also the co-chair, Dr. Danny Sheet from my team. Before we begin, I think it's important to remember where we are in the middle of this pandemic that has crippled our planet. And it's very sad. Our colleagues from the World Health Organization, very few blocks from where we are sitting now, have this official dashboard that I check every morning. And I'm sure all of you check once in a while what is happening with the COVID and with the numbers, the very sad numbers behind it. As of this morning at 8:30 a.m., we had 43,147,494 confirmed cases. And of those, the important number and very sad number is the 1,155,000 people that have died. With those numbers, we are only human. You will tend to become a little pessimistic. But I am here to tell you that we should remain optimistic. And we should remain optimistic because at the same time that this pandemic has crippled most of our nations, and particularly developing nations like the one that I come from, I'm from Ecuador in Latin America. And our people have suffered and continue to suffer, and also the global north. I'm sitting in Europe, and I can tell you, and you have seen in the news, how sad and how the worsening of this pandemic in this continent is accelerating. But regardless of that, I was saying, we have also seen resilience. We have also seen this human spirit to go back at it, to charge again to wherever you were going, to maintain this vision of progress and betterment that we all have. And with that optimistic enthusiasm, I hope, in the middle of this reality, I simply wanted to tell you on behalf of the United Nations and of UNITAR that we have to remember that the world had embarked in September 2015 in this global quest to improve our standard of living, to fight against poverty, to eliminate global hunger, to improve education, to improve health, to improve infrastructure, to improve the use of renewable energies, to protect the environment and the like. Gender empowerment at the center of it all, reduce discrimination, protect the migrant and the refugee, and so on. All these things, I speak very optimistically from a positive point of view. All these things that humanity cares for should not be diminished because of the COVID. And yes, I'm a realistic optimist. And I am aware of what happened, and I just told you in opening, these terrible numbers that we have. However, the human spirit remains high. And that's why I want to invite you today to listen to this conversation, but at the same time, to go and read about the Sustainable Development Goals, what we call the Agenda 2030 for Sustainable Development of the United Nations. And please remember, the UN is not the owner of these things, not the creator of these things. We are simply the custodian. This belongs to 193 member states, to the countries, to those societies. They own these 17 Sustainable Development Goals that are part of Agenda 2030. And the quest against poverty, the fight against poverty remains a top priority that should not diminish because of the COVID. Having said so, we have seen, for reasons that we understand, that governments have been really under financial stress and have deviated funds from the fight against poverty and the betterment of standards of living to fight the pandemic. This is common sense. I'm a former government official myself, and I understand the realities of the day-to-day of a government. But we have to go back at it as soon as it is humanly possible. Our Secretary General, Mr. Antonio Guterres, and my Assistant Secretary General, Mr. Nikhil Seth, keep preaching, that's the word that I want to use, keep reminding us of the need to build back better whenever the moment comes and this pandemic diminishes, hopefully soon, with the advent of the new vaccines. But now, from that general view and this invitation for you to be part of the solution and for you to know more about Agenda 2030 and the Sustainable Development Goals, let me simply say, in briefly introducing this topic, that digital health remains a critical path ahead, remains a top priority to actually make the most of what we already have achieved in issues of technology and development of ICTs, as we call them, information and communication technologies. Digital health is the solution that unfortunately not everyone is seeing. Today you have two experts, one formerly with the WHO, another one from academia and a medical doctor, that will tell you how e-health is the solution, it's the path ahead, and how to do it. But at the same time, they will tell us that pilotitis, I love this word, and I will use it a long time because I have seen what I'm going to tell you and what you're going to describe too many times. The concept of, for a government mainly, but not only for a government, creating a pilot to test something, a good idea perhaps, that can bring a solution for society, and then dropping the ball. That's not good. It's a waste of resources and time and investment of human energy. Pilotitis should not happen. We should have a long-term view, a sustainable view of the solutions that we need to raise for society to be better and for the standards of living to improve. So to talk about pilotitis and why digital health is the solution, I will turn over now this to my colleague, the chairing, to my colleague, Dr. Danny Sheet, who will introduce the speakers. Thank you so much, Danny.
Thank you, Alex, and thank you for your excellent opening remarks as always. And I'd like to join you in welcoming all of our participants to this fifth installment of our Responsible Digital Health Speaker Series. Just a note of standard procedure, I would like to remind all of our participants to feel free to use the Q&A function on Zoom to submit questions throughout the session, and we will try and address as many as possible at the end of the discussion. As Alex alluded to, today's discussion is focused around the subject of pilotitis. Pilot projects can obviously be an excellent way to improve that your concept for the next game-changing digital health innovation works. Indeed, it is often a prerequisite for securing donor support and funding as well. However, we have to think about what happens to those projects that don't work, or for those which, despite successful proof of concept or achieving their objectives, may not succeed in securing further donor funding, or for which donor funding may dry up, or even for those where there was never any intention in the first place of scaling up in the region where the pilot took place. Often such pilots take place in resource-limited settings where needs are high, and the successive running of short-term and short-lived pilot projects stand to cause more harm than good. So extensive is this problem in digital health that the term pilotitis has been coined to describe it. Not only is pilotitis ineffective at generating lasting positive health impacts, but it also destroys community trust, local government trust, and can be a massive waste of resources. And more often than not leads to tech dumping as well, when devices used in pilot projects are no longer needed or are incompatible with existing tech infrastructure or future infrastructure. So in this session, we will learn a bit more about this damaging trend and look at ways to build more sustainable digital health projects. We aim to define exactly what pilotitis is, describe the ways in which pilotitis can hinder health development, and identify some approaches to digital health innovation that will help to overcome pilotitis. We're very fortunate today, and I'm very grateful that we're joined by two excellent expert guests. Our first one is Professor Antoine Geisebola. Antoine is a physician and professor of medicine, and also the vice rector of the University of Geneva and director of the Division of e-health and telemedicine at Geneva University Hospitals. He is also the past president of the International Medical Informatics Association, a fellow of the American College of Medical Informaticians, and former associate professor of biomedical informatics at Vanderbilt University. He was instrumental in the design and implementation of the medical information systems at Geneva University Hospitals. And in 2010, the telemedicine and distance education activities led to the establishment of the World Health Organization Collaborating Center for e-health and telemedicine. Since 2015, Antoine has also been in charge of the Innovation Center of Geneva University Hospitals, and his current research focuses on the development of innovative knowledge-enabled information systems and computer-based tools for improving the quality, safety, and efficiency of care processes at the local level of the hospital, the regional level of community healthcare informatics networks, the national level with implementation of the National e-health strategy for Switzerland, and at the international level with the development of a large telemedicine network in developing countries. Our second guest today is Dr. Najib Al-Shorbagy, an independent consultant in knowledge management and e-health, the president of the Jordan Library and Information Association, and president of the e-health development association in Jordan. Najib is also a vice president for MedInfo with the International Medical Information Association, part-time lecturer and researcher in medical informatics at PLR in Germany, and former director of the Department of Knowledge Management and Sharing at the World Health Organization headquarters in Geneva. Hello to both of you, Najib and Antoine. A very warm welcome to the series and many thanks for taking the time to be with us today. Anton, I'd like to give you the floor first to deliver your presentation and a nice introduction to the concept of pilotitis. Antoine, over to you.
Thank you, Danny, for this introduction, and thank you, Mr. Meja, for an enthusiastic and inspiring vision of what we need to do despite of the difficulties that we're facing worldwide. As the title of this discussion implies, there are different kinds of epidemics, and the one we are going to be discussing today is one of the hurdles that we've been facing for the last decades in trying to not only implement but demonstrate the impact and scale of digital health interventions. As one of the my famous colleagues, Marcel Tanner from the Swiss Tropical and Public Health Institute says, pilots always work and never scale. And even though there may be exceptions, this seems to be the rule. And this is really important to realize, because we all believe that by developing pilot projects, we're going to be able to demonstrate convincingly that we can make a difference with the digital health interventions. And this is not so easy. Digital health interventions are complex interventions. They require an alignment not only of technology and skilled users, but a lot of other factors, social factors, operational issues, logistics issues that need to be brought together and make work so that you can actually scale those interventions. The other aspect that has been very frustrating for us over the last decades is our limited ability to prove what we obviously are convinced. I think we should stay to the previous slide if that's possible. Prove what we've been convinced is that those tools can make a difference, but how much of difference do they make? How do they compare with other public health interventions such as vaccination or providing drinkable water is something that we're still very poor at doing. And pilotitis, the fact that we've been mostly focusing on small-scale demonstrators is one of the problems that we need to blame. I think the first use of this word came from the early 2010s, and this image that you see here, this map with the red circles, is an image that was produced in 2012, showing the number of pilot projects in digital health interventions in Uganda. And this is probably not, you could have similar maps probably throughout the world, you know, from the developing world to the more affluent world. But what was important here was the understanding that having so many pilot projects was not a desirable situation, because each of those pilot projects would not only use resources, develop systems that may not be working with other systems, that may not be interoperable, but also would only affect a limited population and therefore limit the ability to demonstrate impact in such a way that would be useful for decision makers. I think what was also very interesting is, next slide please, was the reaction of the health authorities in Uganda. And I think, at least for me, was one of the first times that the authorities decided to refuse additional pilot projects and regulate what could be done in the country so that the existing projects could eventually demonstrate impact and eventually be scaled. And I think that's a very interesting example of a government starting to say, even if you come with the money, if you come with the tools, they may be disruptive of our national strategy to actually deploy a sustainable and impactful system. And so they decided that there were several conditions that had to be met before new pilot projects or new initiatives could actually be implemented. It had to be approved by the government, and in terms of sovereignty, this sounds evident, but it is not in many countries. There need to be sustainability mechanisms that should be in place, interoperability with at least some of the key functions of the system, and DHIS2 is the District Health Information System that is used to pilot the healthcare system. And there should be institutional structures and obviously that the project, the working group has reviewed and recommended its approval. So basically saying it's important to have projects, it's important to have initiatives, but they need to be framed in such a way that if they work, they can be integrated in the strategy and they can be scaled. Next slide, please. And so there have been different ways to move forward on fighting this e-health pilotitis. A key one is the one that has been supported by WHO for more than a decade now. And it's really encouraging member states to develop national e-health strategies. And this has happened pretty much now over the last well, I would say 15 years that this momentum was initiated by WHO, but it's not, you know, you need more than national e-health strategies. You need to use norms and standards for interoperability so that every project, every initiative doesn't come with its own way of describing the world, so that you can actually connect those systems and scale them. And that's probably the most difficult part, and we still need to make progress, is how do we foster coherent and reproducible evaluation of e-health interventions. This has been a strong topic of discussion for the last 10 years, and I must admit that we are still struggling to get this as a mainstream activity. And obviously, coming from an academic environment, I'm to blame, like many other academic environments. We should be developing toolkits, we should be developing methods, we should be developing indicators that can be used by those implementing systems to document the benefits or the lack of benefits of e-health interventions. That requires, and that's the second column, implementation science approaches. This is not so easy to enable or to develop randomized controlled trials of e-health interventions. It's quite complicated to control unless you're focusing on a very specific function, and that's usually not what we want to be measuring. So you have to realize that implementation comes with a very diverse universe of information and data that you need to deal with. And just as you know, genome is a broad view of genetic. We've coined this term implementome and implementomics as the methods and science to grasp the complexity of implementation of e-health interventions. And that's a domain we want to be able to develop and make a difference. We want to focus the evaluation not just on usability and feasibility, but on impact for health outcome. How does this e-health intervention truly diminish maternal and neonatal morbidity and mortality? Those are the kind of things we need to be able to measure, and this is quite difficult, but this is only at that price that we're going to be able to provide evidence that is usable for decision makers to decide whether this is the right way for implementing, for strengthening the health system, or whether there are other alternatives that may lead to better results. We need to be humble, and we need to be stubborn at producing those evaluations, because that's the kind of evidence that can really make a difference. So those were my initial statements, and I look forward to further statements and to the discussion that is going to follow. Thank you for your attention.
Thank you so much, Antoine, and thank you for giving such a nice overview of the existing challenge and some of the progress that's been made, but also some of the challenges that still lie ahead. And perhaps we'll have a webinar in a few months' time on implementomics and look at the next stage, moving on from the challenge of pilotitis. Also, good to re-emphasize that digital health interventions are extremely complex, and hopefully that's a message that our participants have received over the past few weeks as well, with the various subjects that we've covered in the webinars. And also encouraging as an academic to see one of the examples where science and scientific manuscript directly influence policy there in Uganda, because it doesn't happen too often. So, yeah. Moving on now to Najib's presentation. Najib, I'll hand over to you to give your opening remarks. Thank you. Just unmute yourself there, sorry.
Okay. It's a pleasure to be here, and it's an additional pleasure actually to listen to Mr. Alex talking about the Sustainable Development Goals. And since we are talking about pilotitis, and the challenge is how can we get rid of these pilotitis, these pilots, and sustain what we are doing. So there is some standard definitions of sustainability, in addition to, of course, the Sustainable Development Goals, which says that it's the ability to maintain or support an activity or a process over a long term. Of course, when we talk about sustainability, we talk about actually keeping the resources going, keeping the economy, keeping the life in that particular thing, rather than spending 1 month or 1 year or 2 years and then forget about it in terms of pilots. Now, there are 3 types of sustainability for e-health or digital health applications that one can think of. There is what is called the economic sustainability of that technology. And then there is the social sustainability of this particular technology, the digital health. And then there is the organizational sustainability of e-health technology. And then there is the true interaction between theory and action through knowledge sharing and learning. And what actually Antoine described and what has been in discussion is the silo mentality, this is mine and I don't share with other people. So the true interaction between the theory in terms of the academia doing something and the people on the ground doing something is extremely important. Now, there has been a lot of research actually trying to find out why do e-health or digital health projects fail? What is the problem with them? Because one of the bad lessons that we have learned actually is that the good things are never shared because people like to keep for their own. And if the project is a failure, then nobody tells how and why it failed. So the lessons are not actually shared, and nobody knows what exactly the problem. So there was a survey actually done by WHO at some point, and then they found out that there is lack of proper needs and readiness assessment. They just do it without looking at what are the problems. There is lack of vision, strategy, and national plans. This is another thing. The ecosystem of the e-health is not actually conducive enough to allow for people to do this assessment and this long-term planning and this strategizing of the issue. There is lack of information and awareness about ICT application. It's nice to have computers. It's nice to have mobile systems. It's nice to have this and that. But the real problem is not really looking at what this particular equipment or device can do to improve health situation and to improve the well-being of people. There is the computer illiteracy issue, especially among the healthcare professionals. We have two levels of people, one that are experts in computers, and the other part are very good and they are experts in health sciences. So meeting the two groups and discussing and all that is not really the case. And there is, of course, the financial issue, insufficient resources to meet these costs. And then there is limited experience in medical informatics. And that is a problem actually that we see in many countries. They don't have medical informatics education. They don't have training. Those who are trained, actually, they come either from outside or they are excellent in what they do, but they did actually short-term training so that they are trained by the companies rather than by academic institutions, by universities, and so on. And then, of course, there is the weak information and telecommunication infrastructure, meaning that we would love to have this telemedicine, we would love to have this e-health record system, we would love to have contact tracing, but the infrastructure is not good enough because of too much pressure on the internet, or because the cables are outdated, or the bandwidth is not enough, and so on. And of course, the absence of legislative, ethical, and constitutional framework. And then there is nothing really worse than having the data that is being collected from people, from patients, about projects and about the patients being shared and being given away, and people having access to it. So the legislative and ethical and constitutional frameworks are important to support these kind of projects. Otherwise, in a pilot stage, you can control everything because it's simply under the control of the 10 or 15 group that is actually taking care of that particular thing. So when they do the pilot, they don't really look at the different things. We put every single thing that we know in legislation, in infrastructure, in education, into that pilot. And then when we finish that pilot, we just get rid of all these people, and then the project fails. Next slide, please. So what I thought, actually, there are I picked three interrelated elements that we need to really consider and really take into consideration, so that we can actually eliminate, or we can phase out, or whatever the exact term actually for pilotitis elimination. These three terms work together. One of them is sustainability. For them to be sustained, they have to be, as I said, legally and ethically supported. Otherwise, they will not be sustained. They have to be seamlessly integrated in health systems. We have seen so many actually projects that are parallel to the health system. They are not integrated into that particular system, which means actually the health system people don't get involved, and it does not really provide the healthcare services that they are aiming at. The governance structure and the engagement structure of the policymakers is not in place. And we have seen examples actually where equipment and projects and money is coming without proper consultation with the authorities. And then it is based on or part of an overall strategic plan. It has to be part of what the system is trying to do. Otherwise, it will be an imposed, or it will be parallel, or it will be outside the scope of the system. And then it has to be managed by appropriate quality and quantity human resources to manage, to do, to run, and to use the system. And that includes actually the patients. It includes the healthcare professionals, nurses, doctors, and includes the managers, and includes the policymakers, the leaders in that process. Otherwise, it will continue to fail, and it will continue to succeed as a pilot, but not as a scaled up thing. And this is the second term that I like, actually. It's about scalability. We have to improve the evidence that this thing is working. Otherwise, we will just continue to testing, continue to piloting, continue to do things without proper evidence that is documented, as Antoine has said. We have to do that, and we have to share that knowledge with other people so that they make benefit of that. The other thing, the institutionalization. You cannot actually scale up any project or any idea as an individual. If it's not built in the institution, it will not fly. Of course, having people who are interested, who are genius, who are good, and all that is a must. But unless that thing, that project, that deployment is not institutionalized, it wouldn't work. The technology has to be integrated. Otherwise, it will be, again, silos, and will be out of standardization and interoperability. We have to find the right financing and funding resources beyond the donors. So if the donor comes and spend X amount of dollars, 100,000 or whatever is the amount of money, we have to have an exit plan, and we have to have a plan which will sustain what we are doing beyond what that donor is providing. Because the donors, in many cases actually, and we have seen that from Ghana and from other countries, where the money is becoming a burden on people actually. So it's not worth having more money and then less engagement by the authorities and less engagement by the healthcare institutions. We have to have some global policies and national strategies and roadmaps to support what we are doing in the health technology. We have to have a digital health community that has creative, persistent, and passionate innovators inside it. Otherwise, it will continue to be something that is imposed, that is coming from outside, and then whenever they finish the money, whenever they finish that particular program, they will just go away. So we need actually to create that community to be able to scale up. And then the very important part, which is learning. We don't learn from failure, unfortunately, in technology in general, information technology in general, and in digital health in particular. We have to learn from the past. We have to document, as has been said, we have to document the success and the failure. We have to publish that, we have to share it, we have to put it in documents. We have to do what is called change management. It's not worth actually just having computer technology and keeping the old way of doing whatever we are doing in health or in healthcare or in medicine or whatever. We have to change. We have to do things in a different way. We have to create team spirit and plural thinking. Otherwise, it will be the different teams working and different people actually contributing, but not adding to each other and not adding to the global perspective at a country level or at a community level. And then there is this localization and contextualization of the solutions. What might work in Switzerland or in Canada or in Brazil or other countries might not work in a local place like in Jordan or Syria or Lebanon or Iraq or any of these places, because of the language, because of the culture, because of the tradition, because of the procedures, because of the bureaucracy that is being followed in some of these places. And then we have to change and adopt the culture of ICT for health. Otherwise, we will continue to say, and that is the case actually in many fora, in many places, pretending that you cannot introduce ICT for health. You cannot do this. You have to touch the patient. You have to do this and that. And I have examples actually of people resisting information technology for health because of the fear that it will take their place. It's not being enough for them to do what they want to do. And the last thing, and the one before, is evidence building and its translation. So we have the evidence, we have the monitoring and evaluation, but that has to be translated into action. It has to be translated into knowledge and to improvement and learning from the mistakes and learning from whatever we are doing. So I stop at this point, and then if there is any question, I will be more than happy to attempt to answer within the coming minutes of this session. Thank you so much.
Thank you, Dr. Najib, for giving us an overview there of what leads to the failure of pilot projects, but also what steps need to be taken in order to ensure their sustainability and their sort of long-term development, from sustainable financing to interoperability of digital systems. With that, I'd like to transition to the discussion component of the session, and I'll do so by talking a bit more about some of the negative consequences of pilotitis. Najib, mistrust in science and government is obviously a growing problem worldwide, impacting not just the health sector, but also a whole range of others too. How can a move away from short-term unsustainable health pilots help to improve this situation and ultimately build trust in digital solutions as an integral part of future-proofed health systems?
Thank you. Thank you very much, Danny. I think we have to see what is the opposite, what is the word that we use, what is the belief that we have, which is antitrust, or with having people to trust what we are doing. Number one, we have to make sure that we have enough evidence, and that evidence is built on data, that is built on the real experience of what people have. Otherwise, it will continue to be academic exercise. It will be just for the sake of publishing. So we have to analyze, we have to provide evidence that this works because of 1, 2, 3, and this does not work because of 1, 2, 3. This is number one. Number two, there is no tradition of maintenance, of monitoring and evaluation of e-health projects, unfortunately. We have to build in the concept of monitoring and evaluation, which means actually we have to create specific indicators. We have to create a specific way of measuring our success on a monthly basis, twice a month basis, or a half a year, and so on, so that we can actually see if we are progressing and what are the problems. And that will contribute to building the evidence, because there is difference between building the evidence and monitoring and evaluation. And we have to be clear about that. The other thing is we have to build trust by transparency. The technician has to be transparent with the patient. The patient has to be transparent with other people. The manager has to be transparent. We should not really be fearful of expressing our fear of something. And we usually fear what we don't know. And we don't trust because we don't know. We don't trust because we don't have enough transparency, because people don't tell us the whole truth, or we discover from side way or from other ways what is the truth. And the last thing is to make sure actually that to build the trust, we have to make sure that the right human resources are put in place. You cannot actually bring anybody from anywhere and say, I'm giving you this project, you are in a position to control and you lead this particular thing. So we have to have people who are dedicated, people who are motivated, people who are knowledgeable, and they have the skills and the experience to lead some of these things. And that will contribute actually to building the trust between the different components, different stakeholders that we have. Otherwise, we will continue to accuse each other and continue to accuse those who are doing or not doing, and determine that this does not work, and then I leave it unattended, or I leave it for somebody else. Thank you.
No, thank you. I fully agree. And I think, you know, as long as we don't have that trust, we will never have like full commitment and full support behind these kind of digital health interventions, both from a personal level, but also from a government level and a policymaker level as well. And that also comes back to donor funding and sustainable financing point that you made. Like once you lose the trust of donors because you've just whittled away their money on various pilot projects, it's very hard to get that back. And I think that leads me on to my next question for Antoine, actually, if I might come back to you, Antoine. So what kind of impact does this lack of success in developing pilot projects into full-term, long-term sustainable digital health solutions have on government appetites and donor appetites for these kinds of interventions?
I think the trick is that digital interventions in general, and that's true also in the domain of health, are basically, people want to try these because they promise a lot of functionality, a lot of solutions that are faced by many health systems, whether a lack of expertise in remote areas, whether it's about complete difficult infrastructure for moving patients around. So there's a lot of maybe hype in what can be done with those tools, and you know they produce nice images on TV. It's nice to be associated with those experiments. They give a very positive view of what is going on and what can be achieved. So they are not scrutinized as much as other technologies or interventions in health, and especially in public health. So this is good because there is a lot of enthusiasm for it. But this is also dangerous because if you cannot show that you have impact, you cannot rely on hype for very long. And you know everybody's aware of this this curve of hype and what comes after the hype, which is the trough of disillusionment on the I think the Gartner hype cycle. So you have to be very careful, because once you've lost a trust in a tool or in technology, once you've disappointed, it's much more difficult to regain it. And this is very true when we deal, for instance, with security issues and privacy issues in digital health. It takes a long time to build momentum and to build and sustain enthusiasm, and it's very easy to lose it. And I'm afraid that at some point governments will look at those things beyond the hype and realize that is this all what we gained in the end? A few pilots scattered throughout the territory and nothing to really change the way we actually enhance our health systems. So I think the lack of evidence, and we've seen that during the COVID crisis, and you probably followed all the discussions around the benefits or absence of benefits of some medications. You know, I think we are in the same space now with health interventions, where the hype can go only so far. And after that, you need true and solid numbers to actually convince not only the decision makers, but the population that this is a worthy effort. So that's, again, advocating for less pilots, more evidence, more strong evidence, more evaluation.
No, I fully agree. And I think we need to ride the hype and make the most of it, because I do believe, and I think many of us believe, that digital health solutions, or at least digital integrated into existing health systems, is the way forward. And we have to use it, and we have to avoid, you know, losing all trust and ending up, as you mentioned, in this trough of disillusionment, which I always enjoy the term, but never want to find myself in. But yeah, absolutely. We need to make the most of the hype. And I think that brings me on to my next question, actually, which is, you know, obviously this hype is one of the reasons for this huge number of pilot projects that we see. But also another reason, it's probably safe to assume, is that, you know, often these projects are extremely siloed in their nature, their design, and they completely lack experience sharing. And how do we improve awareness of existing and past projects and encourage this kind of experience sharing going forward? Najib, we'll start with you for that one, if we can.
Thank you very much. A few things come to mind. Number one, there are many digital health solutions. Unfortunately, they come to solve a problem that does not exist. So whatever the market is offering, they try to impose it, they try to make it available and deploy it in countries, which means actually that I don't have that problem. Why should I care about the technology? Why should I care about that particular solution? This is one problem, which actually contributes to losing the trust. It contributes to people not believing in what the government or the stakeholder or the donor is doing. The other thing is, one size fits all never works. And in particular, in countries, we have to think of solutions that are 100% fitting the need, and they are fitting the purpose for what they are actually being brought. Otherwise, there is no point of assuming that it will work because it works in other places. So one size does not fit all. This is extremely important. The other thing, we have many situations in which actually the favor is given to the solution rather than to the problem, which simply means that if it's a package solution and it is provided by this donor and it's nice to have that particular solution, why should we leave it? And the example that was cited by Antoine about Uganda, we have 193 countries. I can challenge actually how many countries and how many institutions will have the courage to say, I don't want your money, but I want a solution that will be seamlessly integrated in what I'm doing. I want interoperability. I want the pilots or all the projects to fit in what is the policy at the country level. How can I make sure that what you are providing is actually supporting healthcare and is contributing to achieving the Sustainable Development Goals when it comes to health, SDG number 3, for example, universal health coverage, and the rest of it. If it's not fitting for that particular thing, you will not actually, no matter what you try, no matter what you provide, no matter what you write actually in the media to create awareness and to improve about the image and all that, it will continue to be actually, show me good example of how it works, show me what would be the benefit for the patient, what would be the benefit for the healthcare provider, what is the benefit for the economy of doing that. And that is actually the evidence. That is the reason why people do resist or accept on the other side certain solutions. Otherwise, we will continue to talk about it. We will continue to promote it, but not necessarily doing what we are preaching and not what we are supposed to do. And that's actually one big reason that WHO previously and now and many UN agencies, including UNITAR, actually is trying to make sure that people are aware, that people are on top of the knowledge of the thing, being a digital health or whatever it is called, and at the same time, seeing is believing. If you talk about it, if you write about it, if you do whatever you are doing actually without showing a good example of how it can be done and how impactful this thing is, it will never be done. And just one example that I'm really proud of mentioning, the digital health system that was developed by the UNRWA, the United Nations Relief and Works Agency, and their headquarters is in Amman. And the auditors, and you know, the auditors, they love actually their work and they love to audit the United Nations, and they love accusing United Nations of 5 pennies are not spent properly, and this stuff, where did you come from? But we have a report from the auditors, actually, international auditors, who came and audit every single line in the system and every single penny that was spent and every single patient that is recorded in the system. And what they discovered actually, that it has reduced the time that is needed for the patients to come to the doctors and see them. It has reduced the number of drugs that are given for as antibiotics. It has increased the time that is spent by the healthcare provider, the nurse and the doctor per patient. It has reduced the cost of the whole operation, and so on. And that's what we want. That's what we would like to see, actually, things that are proven that it works and it has been providing benefit. Thank you.
Thank you, Najib, and thank you for sharing that excellent example. And it's kind of a shame, I think, that it had to come down to the auditors finding this out. And I guess that comes back to the point that Antoine made earlier in his presentation regarding monitoring and evaluation. And so I guess my next question to Antoine, going on from that, is how can we start to better develop a true way of measuring health impacts and health outcomes? Obviously, when comparing intervention versus non-intervention in the real world, it is quite difficult and quite challenging. Obviously, there's kind of a pounds and penny way of doing it that Najib mentioned, but what other ways can we start to build this capacity?
Well, I think there are different ways to move forward. The first one would be that every project should have embedded an evaluation that is going beyond just evaluating the activity and the feasibility and the technical aspects of a solution. I think those financing those projects, whether those are governments or donors or research institutions, should make sure that what you get in the end is not just a tool, but a tool with an evaluation of its impact. I think that's the first thing. Projects should include impact evaluation by default. Now, as we know, impact evaluation is not so easy. And what we see is that there are a lot of different metrics and methodologies that are used. And probably one thing that could be helpful is to have agreements on what should be measured, maybe a minimal set of indicators that should be measured with all interventions, and maybe domain-specific indicators. And that would have two benefits: is to lower the difficulty of reinventing new metrics and new indicators for every project, which is not done by it's done because there's not a lot of guidance, but also maybe the ability to facilitate aggregating information from multiple interventions and being able to do have larger numbers that may help increase the understanding. So having a toolkit that people agree upon that should be the minimal evaluation, and then domain-specific evaluation, I think is one way forward. And the third way is developing mechanisms that rely not only on studies, but on reports, on various kinds of information that can be gathered and brought together. And that's the idea of this implementomics. You know, we need to be able to collect data, and some of it will be anecdotes, some of these will be randomized controlled trials, others will be just documents that have that are written in free text and can be analyzed by natural language processors or artificial intelligence, and really extract as much as we can from what exists and make it available in such a way that facilitate the sharing of information, facilitates the sharing of knowledge, facilitate the learning from successes, but also the learning from mistakes. And so, for instance, having registries of ongoing trials, which is the norm in most of the clinical research now, is something that we should also expect from e-health interventions. Those should be recorded, and so, for instance, shouldn't be publishable unless they were recorded, as is the situation with much of the clinical research. So I think we can learn from other domains that have made much more progress in sharing knowledge, in the reproducibility of scientific interventions. I think we need to learn from that and actually apply that in the field of digital health interventions.
Fully agreed, and I must admit I'm very happy to hear that you and your team are working on this implementomics topic. And as I said, I think it certainly warrants its own webinar in the future. Hopefully, if you're willing to work with us for that, I think it would be great to have you back for that. And obviously, you mentioned there the idea of experience sharing as well. And I think a lot of the lack of experience sharing oftentimes isn't a lack of willingness to do so. It's just a lack of interoperability in methodologies and also data generated by sort of poorly designed projects. And so, you know, thinking about these challenges, Najib, how can these things often lead to a premature termination of a project, for example, a lack of scalability that comes from a lack of interoperability and an ability to share experience? You're muted still.
I can think of a number of things actually that can lead to abandoning a project or stopping it, and it becomes described as a pilot, and then it will go away. Number one, the priority setting in a number of places does not exist, which means actually that we probably need to digitize or to have an electronic something, digital health in this area, but the priority is wrong. Priority in selecting what should be automated, what should be computerized, and of course priority at a higher level that this is not our priority now. Digital health is not important. So let's spend the money somewhere else. And then the donor insists, or the government insists, or they impede the digital health as part of the ICT strategy, and then they spend 100,000 or $1 million or whatever just to for bookkeeping rather than for making an impact on the ground and on the people. So that is one big reason. The other thing is that in a number of cases, we have this division, we have this sort of migration or split between the two communities, the engineers who are dealing with information technology and computers and systems and all that, and those who are dealing with health sciences. And the problem actually is that they have to come together, they have to discuss. Somebody has to bring them so that they discuss and they take decision based on the understanding of what the technology can do to help health. And that's where actually even a long time ago, the WHO was working with the ITU, because the WHO is dealing with health and the ITU is dealing with the ICT or computer science or telecommunication. And that should be reflected in countries. But if the health people go in one direction and the ICT people go into another direction, then they will never meet and they will never actually build something. And that the direct result of that actually is weak projects, weak implementation from this side or from that side, because they simply don't communicate, they simply don't look into the problem. The other thing is how many countries have full-time or people who are working on digital health in countries. And I know for fact actually that pilotitis is not an issue in developing countries only. It's everywhere. Where we have a shortage of people who are dedicated to do that, then these people are even not named, not having a position description and the benefits of being in charge of technology. If you take an engineer, if you take a medical doctor, if you take a pharmacist, they prefer actually to take the benefit of being an engineer or a pharmacist or a physician rather than a medical informaticist and information. And that is by itself actually is impeding and not allowing people to develop, not allowing projects to sustain, simply because we are not providing enough motivation for people who are doing the digital health projects or the digital health movement and so on. So the burden is actually on the stakeholders represented by the government, by the funding agencies, by the companies that they are doing that, and of course by the academia. They have to come together so that they make the influence, the impact as we wish to have. Thank you.
Yeah, I fully agree. Thank you, Najib. And I also, I think the importance of empowering people, empowering the public, empowering patients, but also empowering medical staff and empowering those that are championing digital health in their countries is vitally important, giving them the recognition that they deserve, as you say. And I'm glad that you mentioned there that pilotitis isn't just a challenge in developing nations. It's also a challenge globally and in high income countries just as well. And that point was raised in the chat function as well. Unfortunately, as so often happens in these really interesting discussions, we could have chatted for hours, I'm sure, but the time has come where we need to wrap up. Of course, I hope that we can welcome you both back in the future, hopefully to discuss this implementomics subject. And all that remains for me to do then is to thank both of you. Thank you to Dr. Najib Al-Sirbazi for joining us today from Jordan, giving up his evening to join us in this discussion generously. And of course to Professor Antoine Geisebola, who is normally a very busy man, but even more so at the moment, thanks to the explosion of COVID-19 cases in Geneva and the challenge of managing that at HUG. As always, I'd like to thank my colleagues here at UNITAR, and of course, a big thank you to our participants for joining us today. Please don't forget to join us next week at the same time for our last session in the series on scaling up digital health, which is a nice natural step from today's discussion. And yes, thank you all again, and I wish you a very pleasant day.
Thank you very much for the opportunity.
Thank you. All the best.
Thank you for the opportunity.
Thank you so much. Bye-bye.
Bye.
Bye.